Pediatric Consultant at Santa Rosa Hospital and Medical Center, Santa Rosa Community Hospital, Polymed Hospital of Santa Rosa, the Medical City South Luzon, First Cabuyao Hospital and Medical Center, and lastly at Medicard Santa Rosa. With warm welcome, our moderator for tonight, Dr. Maria Jennifer D. Hermoso.
Hello.
Yes, go on, Doctora.
Hello, thank you. Thank you for your introduction. For our first speaker, I'm so excited to introduce her because she was one of our most loved consultant during my residency training. Just a brief background, she had her post-residency fellowship at the UP General Hospital, Pediatric Infectious Disease, post-residency in Pediatrics, Philippine Children's Medical Center. She had her Doctor of Medicine at the UST Faculty of Medicine and Surgery, and she graduated BS Psychology at the University of the Philippines, Diliman. For her current positions in hospital affiliations, she's a fellow of the Philippine Pediatric Society, a fellow of the Pediatric Infectious Disease Society of the Philippines. She's an editor of the PPS-STC journal. She's a PPS-STC representative for the DOH National Antibiotic Guidelines Committee, and she is also a clinical associate professor at the UP College of Medicine, PGH, Department of Pediatrics. She's a medical specialist at the Amang Rodriguez Memorial Medical Center and at Pasig City General Hospital, and an active consultant at the Marikina Valley Medical Center and Metro Antipolo Hospital. Now, to talk on the updates in the TB case finding, diagnosis, and management, let us give our speaker a round of virtual applause. Let us welcome Dr. Carmina A. Delos Reyes.
Good afternoon, everyone. I want to confirm that you can see the slides.
Yes. Yes.
Yes, Doctora, proceed.
Okay, thank you. So thank you for this opportunity to deliver to you updates on TB case finding, diagnosis, and treatment. Okay, my objectives for this presentation are to discuss the current approaches to TB diagnosis and treatment and discuss ways to move forward amidst this pandemic. To achieve these objectives, this is the outline of my presentation. So tuberculosis is a communicable disease. It is a major cause of illness affecting nearly 1/4 of the world's 8 billion population. It is one of the top causes of death worldwide, and it used to be a leading cause of death from a single infectious agent until it was replaced by SARS-CoV-2. The causative agent, as we know, is Mycobacterium tuberculosis, which is spread efficiently through the airborne route. So the disease typically affects the lungs, but it can also affect other body sites. The good thing about tuberculosis is that it is both curable and preventable. Now, what is the burden of TB in children? Based on the Global TB Report for 2021, in the preceding year, there were nearly 10 million people who fell ill with TB, and majority of cases were in males. 11% of these were in children. TB deaths accounted for about 14% of the global total. So that's 1.3 million deaths, and 17% of these were in children. The regions with the highest TB cases are Southeast Asia, Africa, and the Western Pacific region, where the Philippines belong. Unfortunately, we continue to be one of 30 high TB burden countries, which account for 86% of new TB cases And we are one of 8 countries which account for 2/3 of the global total. So the Philippines in this report ranked 4th, and we contributed around 6% of the cases. So this is 600,000 of the 10 million. So this is the estimated TB incident in 2020, and we can see that the Philippines is a high burden country for tuberculosis, and we have about 500 cases of TB per 100,000 population. Drug-resistant TB continues to be a public health threat, and it is more commonly seen among previously treated cases. So this highlights the importance of screening for drug-resistant TB, especially in those with a history of previous treatment. Now, there were a lot of challenges encountered by the TB program because of the pandemic. In fact, the pandemic reversed years of progress in providing essential TB services and in reducing the burden of TB disease. The global targets went off track. There was a large global drop in the number of people diagnosed and reported with TB. And 16 countries accounted for 93% of this reduction, with India, Indonesia, and the Philippines topping the list. There was reduced access to TB diagnosis and treatment. Naturally, the number of deaths followed, and there was an increase in deaths by more than 100,000 comparing the 2020 to the 2019 data. What were the specific challenges encountered? So the TB continuum of care was displaced. The case notification rate decreased by almost 21% after the community quarantine was imposed, and patients themselves did not access the available TB services because of their perceived risk of COVID-19 infection. And these were the specific challenges encountered, from TB screening to diagnosis to treatment and prevention. Okay, so how did we cope? So fortunately, there was this National TB Control Program Adaptive Plan. It was released between the second to third quarter of 2020, and this NAP provided specific doable measures and adjustments to the current implementation of TB care guidelines. So it issued clear guidance to TB providing facilities and on how to continue TB services, and it complemented the COVID-19 response of facilities and healthcare providers. Specific guidelines within the NAP are the following: the continued observance of minimum public health standards as we continued to see both COVID-19 and TB, continued screening of presumptive TB cases, implementation of TB biosafety and infection prevention and control measures, flexible treatment, management, and provision of anti-TB medicines, keeping in mind the limitations of our patients, and use of digital technology for monitoring, virtual consultation, and even TB screening. So let us now move on to TB diagnosis and treatment, because we know that we need to do a lot to reverse the effects of this pandemic. So let me now walk you through the DOH NTP Manual of Procedures, which was released in August of 2020. So this MOP really came as a response to the UN General Assembly high-level meeting on TB back in September of 2018. In this meeting, countries committed to ending TB globally. The Philippines in particular committed to finding and treating more than 2 million TB patients. So this meeting emphasized the shift in strategy from TB control to TB elimination, which required new tools, approaches in screening, diagnosis, treatment, and prevention. Revisions on screening and diagnosis included the mainstreaming of X-rays as a screening tool for adults and the adoption of a rapid diagnostic tool with better accuracy to detect both TB with the added advantage of detecting drug resistance. Revisions on treatment, on the other hand, included new regimens for drug-resistant TB without the injectables. But the most important emphasis on the guideline was the focus on patient-centered TB care. So in the past, patients were mere recipients of TB services, but in this current guideline, patients are active partners in healthcare who are capable of making informed decisions for prompt diagnosis and effective treatment. Okay, so let us now move on to TB screening and diagnosis. So systematic screening refers to the systematic identification of these presumptive TB cases in a predetermined target group using exams or procedures that are applied rapidly. Systematic screening can be through intensified case finding, or active case finding, or enhanced case finding. Now, just to differentiate one from the other, intensified case finding refers to the systematic screening in health facilities among all consults, even if the reason for consult was for another condition. Active case finding refers to the screening implemented outside health facilities among high-risk groups by bringing the exam to the community, such as a chest X-ray. While enhanced case finding refers to the screening in the community through house-to-house visits using symptom screening. For children, only symptom screening is recommended. And screening starts with the identification of presumptive TB cases. So if the child has at least one of the following signs and symptoms suggestive of TB, such as chronic cough, or unexplained fever, or unexplained weight loss or failure to thrive, classify as a presumptive TB case. If the child is a known contact of an active TB case, ask if with fatigue, reduced playfulness, decreased activity, or is not eating well. And if present, classify as a presumptive TB case. If the child has an X-ray, review the plates, and if suggestive of TB, classify as a presumptive TB case. Now, moving on to diagnosis, once a presumptive TB case is identified, confirmation through bacteriologic testing through gene expert must be conducted. Expert shall be the primary mode of testing both for adults and children with pulmonary and extrapulmonary TB. And if drug resistance is highly suspected, all the more that we should push for expert testing. Okay, so this table shows the appropriate respiratory specimens with their corresponding volumes to be sent for expert testing. Now, following this diagnostic algorithm, if the expert result turns out to be positive with MTB detected, classify the case as a bacteriologically confirmed TB case. If MTB is not detected, or the patient cannot expectorate, perform an X-ray if not yet done, and if suggestive of TB in the presence of signs and symptoms, classify as a clinically diagnosed TB case. So the following are the X-ray findings, which are suggestive of TB. In younger children, presence of hilar adenopathies or chronic pneumonias or miliary mottling on X-rays. And in older children, presence of pulmonary cavitations and effusions. If X-ray is normal or uncertain, you may opt to give a broad spectrum antibiotic and follow up the child in 1 to 2 weeks. But with the persistence of signs and symptoms, and if the child is a contact of an active TB case, treat as clinically diagnosed TB. If not a contact of a known TB case, perform tuberculin skin testing, and if positive, classify as a clinically diagnosed TB case. If negative, or if TST is unavailable, in the presence of signs and symptoms or TB risk factors, you may opt to classify as a clinically diagnosed TB case. So we can see that in this current guideline, the tuberculin skin testing is only done as an adjuvant tool when it is difficult to make a clinical diagnosis of tuberculosis. So moving on to extrapulmonary TB, the following are suggestive of EPTB. So presence of gibbous deformity of recent onset, non-painful enlarged cervical adenopathies with or without fistula, presence of neck stiffness suggestive of meningitis or unexplained effusions, a distended abdomen with ascites, and non-painful enlarged joints for which there is no alternative explanation. So in the presence of these, classify the case as a presumptive TB case. So in such instances, again, we need to collect specimen for expert testing and keep extrapulmonary samples as well for future culture studies. And if expert turns out to be positive, again, classify as a bacteriologically confirmed case and initiate treatment. So if specimen for expert testing is not available, you may opt to refer to a specialist for further evaluation. So this table shows the non-respiratory specimens with their corresponding volumes, which must be sent for expert testing. Note that some specimens, such as body fluid aspirates and tissue, must be coordinated with laboratories capable of processing these specimens. Now, for patients with expert result MTB without rifampicin resistance, classify as drug-susceptible TB, and for patients with result MTB detected with rifampicin resistance, classify as drug-resistant TB. So in these cases, we need to collect a fresh specimen for culture and sensitivity testing to first and second line drugs. Okay, so we can see that following the diagnostic algorithm, we can classify our TB case based on bacteriologic status, whether bacteriologically confirmed or clinically diagnosed, based on anatomic site, whether pulmonary or extrapulmonary, based on history of previous treatment, whether new or a retreatment case, and based on drug resistance pattern. So take note that patients with a history of treatment more than 1 month with poor compliance are classified as retreatment cases, and they should be investigated for the presence of MDR-TB. So moving on to contact tracing, contacts of known TB cases must be investigated as well within 7 days from diagnosis of the index case. So again, for children, we start with symptom screening. X-ray screening is done for children 5 years and up, and if the case fits a presumptive TB case, proceed with expert testing. So an alternative to expert is the smear, but is poorly sensitive. And in adults, another test which can be utilized is the TB lamp. If active TB is ruled out, consider TB preventive treatment. So keep in mind that we need to follow up these contacts for a period of 2 years. We need to do symptom screening every 6 months, and X-ray screening should be done annually. At this juncture, I'd like to inform the group of the available diagnostic tests at the National TB Reference Laboratory. So I have classified them into the conventional tests, tests which detect for drug resistance, tests which cannot detect drug resistance, and follow-on tests for the detection of additional drug resistance. Because sometimes it is very difficult to confirm TB cases bacteriologically. So conventional tests, as we know, are the smear microscopy and TB culture. Of course, smear microscopy is able to detect AFB on sputum smears, but it has several limitations. It is insensitive with a limit of detection of 5,000 bacilli per ml of sputum. And so, this usually turns out negative in children. It's also not specific for MTB, and it cannot distinguish drug-susceptible from drug-resistant strains. And the reliability of the test depends on the quality of the sputum submitted. What about TB culture? We know that this is the gold standard for bacteriological confirmation. It is used to diagnose pediatric and extrapulmonary TB from paucibacillary samples. It is able to differentiate TB from non-tuberculous mycobacteria. And the smear, together with the culture, is utilized to monitor treatment response. But it is costly, so in our setting, it costs around nearly 5,000 pesos. There are infrastructure requirements, so it needs a biosafety level 3 laboratory, and there is a long time to generate the results. So it takes weeks for the culture results to come in. There are also tests available at the RITM, which detects both for TB and drug resistance. So we are all familiar with the Gene Expert. This is a cartridge-based nucleic acid amplification test for TB. And an improved version of Expert is Expert Ultra Assay, which has an improved sensitivity because it has a lower limit of detection of 16 colony-forming units per ml of specimen than Expert. So there is another test which has the same principle as Expert. And this is called TrueNat MTB. And if positive, you can proceed with TrueNat MTB RIF to detect drug resistance. So same principle as the Gene Expert, but this is a chip-based reverse transcriptase micro-PCR. Okay, so this is how TrueNat.
Na-mute lang po kasi.
And this is the current WHO recommendation on these tests. Expert Ultra can be used in symptomatic children with signs of pulmonary TB as the initial diagnostic test for the detection of TB and RR utilizing these specimens. Moderate certainty of evidence for test accuracy, both for stool and gastric aspirate, but low to very low certainty of evidence in sputum and the nasopharyngeal aspirate. What about TrueNat and TrueNat MTB RIF? So it can also be used in children and adults with signs and symptoms of PTB as an initial diagnostic test rather than smear microscopy and culture. Now, what about the TB diagnostics, which can detect TB but not rifampicin resistance? So an available test is the TB lamp. So this is how it looks like, and a positive test is read as a fluorescence, as the appearance of fluorescence on the specimen. Okay, so it detects the bacteria directly from sputum. It can be used as a replacement for smear for diagnosing PTB in adults, but not for children. Keep in mind that the WHO guidelines refer to adults as children 15 years and up. So if you have an adolescent patient who is able to expectorate sputum, this test can also be used. So another use is a follow-on test to smear microscopy in adults with sputum smear negative specimens. So what are the advantages? It provides timely results, less than an hour, does not require sophisticated instrumentation, and can be used at the peripheral health center level, provided there are biosafety requirements met, but it does not detect resistance to anti-TB drugs. So this is the current recommendation of the WHO on TB lamp. It can be used as a replacement test for smear microscopy for diagnosing PTB in adults, again, children 15 years and up, with signs and symptoms consistent with tuberculosis. Okay, so this last test, although not available at RITM, also detects TB, but not drug resistance. So this is a strip-based test. It is an immunocapture assay, and the test is based on the detection of the Mycobacterium lipoarabinomannan antigen in the urine. So this is a point-of-care test for populations being evaluated for TB. It is a fast bedside rule-in test, and its utility is in HIV-positive individuals where TB is suspected. And lastly, follow-on tests for detection of additional drug resistance. So this can be done if the expert shows MTB with rifampicin resistance. So you can request for expert XDR assay. So same principle as the gene expert. And it detects resistance to both first and second line drugs. Again, this is also available at the National TB Reference Lab, as well as the line probe assay, which detects genes, resistance genes are made to interact with specific probes, which is able to pick up drug resistance. So again, this is a strip-based test that can detect mutations associated with drug resistance. Okay, so there's the first line probe assay and the second line probe assay, which detects resistance, again, to both first and second line drugs. There are newer tests, but these are not yet available in the Philippines. These are labeled as moderate complexity automated nucleic acid amplification tests, which also detects for the presence of TB and the presence of drug resistance. Now, there is a promising test, the stool gene expert. And this is, it may be pilot tested in the Philippines soon through the stool box method. There are 2 systematic reviews which have demonstrated that both expert and the more sensitive expert ultra, which supports the use of this test to detect bacilli in the stool with high specificity. And this is the principle behind the test. We know that sputum can be coughed up and subsequently swallowed and passed through the GI system to finally end up in the stool. So this is how the test is done. So about this 0.8 grams of stool is added to a sample reagent provided with the expert kit, and the suspension is transferred to the Gene Expert cartridge, which you saw earlier. So following the same principle of expert, DNA extraction, gene amplification, and detection of the TB gene, we can confirm TB bacteriologically. And it is intended to be used in children where it is difficult to confirm the diagnosis of TB bacteriologically. Okay, so you may benefit from coordinating with the National TB Reference Lab should you have any concerns regarding specimen collection and transport. So this is the website to coordinate your specimens with. I'd like to inform the group as well that the public sector can also handle our specimens. You just have to consult with your regional national TB program teams. They are able to zone the TB specimens for the lab network. And I'd like to inform you as well that TB testing is free in the public sector for Gene Expert. And there are actually sputum transport riders supported by the Global Fund to bring these specimens to the laboratories. Now, for the private sector, there is this thing called the Philippine Private Sector Diagnostics Consortium. And this consortium offers not just TB testing, but other state-of-the-art diagnostic tests. So one of which is the Gene Expert at reasonable prices. So should you have any other concerns, this is the website to access. So just check the consortium.ph. Okay, so moving on to TB treatment, these are just general principles and some updates. So we need to emphasize to our patients that our goal is to cure or successfully treat these cases and achieve a very high treatment success rate. So when we say cure, for bacteriologically confirmed cases, we want to document culture conversion and culture and smear conversion. So we are all familiar with these treatment regimens. Regimen 1 is, of course, these are for drug-susceptible TB cases. And regimen 1 is for pulmonary TB and extrapulmonary TB, except for the CNS, bones, and the joints. While regimen 2 is for extrapulmonary TB, involving the CNS and the bones. Okay, so we need to monitor our patients during treatment. And ideally, the earliest follow-up is 2 weeks after initiation of treatment and monthly thereafter. And we need to ensure that they are adhering to the treatment regimen. And if they are missing their doses, we should discuss with these patients and their treatment supporter interventions to improve treatment adherence. And equally important is to perform regular clinical assessments during follow-up visits. So we get the weight for dosage adjustments. We continue to ask about the resolution of signs and symptoms, ask about the occurrence of any adverse drug reaction, and be able to manage minor adverse reactions and continue management of existing conditions and perform the necessary referrals if necessary. So this table just shows the common minor adverse reactions with the first-line drugs. So most can be treated with supportive measures and reassurance. The following table, on the other hand, shows the common major adverse reactions with these drugs. And so if with any of these, we need to stop the drugs and refer for further evaluation. So this table shows the schedule of sputum smear follow-up exams for drug-susceptible TB. So let us just keep in mind that we need to do follow-up smears at the end of the intensive phase. And if positive, we proceed with repeat sputum smears at the 5th and 6th month of treatment. So if the smears remain to be persistently positive at the 5th month of treatment, that is a warning signal that that might be a case of drug-resistant TB. So we need again to send specimen for culture testing. So this last table shows the management of those patients who interrupt treatment. So if the interruption is less than a month, we just continue treatment and prolong to compensate for missed doses. If the length of interruption is more than a month, but less than 2 months, we perform smear microscopy, and if positive, just continue and prolong to compensate for missed doses. But if 5 months or more, on the 5th month of treatment, if the smear continues to be positive, again, declare as a treatment failure and work up for MDR-TB. So if the interruption is more than 2 months, declare as loss to follow up. So again, perform smear microscopy, and if negative, start treatment based on the gene expert test. Okay, so what are the updates on TB treatment? The WHO has released shortened treatment regimens, and these are the updated WHO guidelines. So in children and adolescents less than 16 years of age with non-severe smear-negative disease, where there is no suspicion of MDR-TB, a 4-month treatment regimen may be used. This is a strong recommendation with moderate certainty of evidence. Non-severe TB is defined as TB involving the peripheral lymph nodes, intrathoracic lymph node TB without airway obstruction, uncomplicated TB with effusion or possibacillary non-cavitary disease confined to one lobe and without a miliary pattern. So 16 weeks of treatment versus 24 weeks, 2 HRZE and 2 HR. So this recommendation was based on the SHINE trial, shorter treatment for minimal TB in children trial, which was the first and only large phase 3 trial to evaluate the duration of TB treatment in children with non-severe disease. So this is a multi-center open-label parallel group non-inferiority RCT comparing 4 months versus the standard 6 months treatment in children 16 years and below. Again, with symptomatic non-severe disease. There are also shortened recommendations for TB meningitis. And in children and adolescents with bacteriologically confirmed or clinically diagnosed TB meningitis without suspicion of MDR or RRTB, so this 6-month intensive regimen may be used as an alternative option to the 12-month regimen. So it is given as 6 months of HRZE. But this is a conditional recommendation with very low certainty of evidence and is based on expert opinion from experiences gathered in South Africa. So our local specialty societies are yet to issue guidance whether these will be adopted in the national program. Okay, so I'd like to mention a few things about drug-resistant TB. So while treating our patients, we need to be able to document improvement in signs and symptoms. Again, suspect drug-resistant TB if they fail to show improvement despite treatment adherence. We also suspect of DRTB for contacts of DRTB cases. And again, there is a need to work up patients for DRTB for those who have been treated for more than a month who are poorly compliant. Okay, so these are just general statements on drug-resistant TB. So the regimen consists of 4 drugs for the duration of treatment. Treatment can either be standardized or individualized, and this is always done in consultation with the TB Medical Advisory Committee. And injectable drugs are avoided as much as possible. And the severity of TB disease is determined based on the following: bacteriology, presence of cavitation or bilateral disease on X-ray, presence of extrapulmonary forms, and presence of comorbid condition. Because non-severe disease are treated for 9 to 12 months, while severe disease are treated for 15 to 18 months. So I'd like to summarize with these key messages on the occasion of World TB Day. So TB continues to be a leading cause of illness and death worldwide. This pandemic reversed years of progress achieved over a 10-year period in providing essential TB services and in reducing the burden of disease. And obviously, we need actions to reverse the impact of the pandemic. So the priority is to restore access and provide TB services to our patients such that levels of case detection and treatment can recover. So we know that effective management of TB relies on rapid diagnosis, rapid detection of drug resistance, and prompt initiation of an effective treatment regimen. So we have the available tools and medicines in our midst to put an end to TB. So with that, I'd like to thank you all for listening. And salamat po.
Hello. Hello. Thank you, Dr. Minette, for your extensive lecture. We will now proceed with the question and answer. You may write your questions at the chat box. Okay. So are there any questions? Or very clear, Dr.
So let me allow Dr. Jen, PPS-STC, let me congratulate PPS-STC for this initiative to be able to get updates on TB on the occasion of World TB Day. So thank you again.
Okay. Okay. Dr. May, there's a question here. How young can you give the HRZ from Dr. Eva Tan?
Good evening po, ma'am. So once a TB case is identified, even in the neonatal period, this 4-drug regimen is given, especially if there is if the case is classified as an active TB case. So wala pong adjustments even for very young children. So of course, we have to follow the recommended drug dosages and be able to just closely monitor the occurrence of any adverse event.
Okay. For the next question, what is the role of the adjunctive treatment like vitamin D and zinc?
I have not reviewed the current recommendations as far as their role in TB is concerned. But we know that zinc plays an important role in immunomodulation, while vitamin D, whether or not the child has TB, we know that there are studies on Filipino children showing that majority of our kids are vitamin D deficient. So I think whether or not we are considering TB, these supplements may need to be considered, especially in malnourished children, which is commonly occurring in tuberculosis.
For the next question, when will the tablet form of anti-TB drugs for children be available in the country? What is your take on rifapentine for children? Thank you.
So yung yung tablet form, kasi in the national program, the TB medications come in fixed dose combination containing HRZ, and ethambutol is given as a separate tablet. So yun. Regarding rifapentine for children, rifapentine in the national program is included in the guidelines as prophylaxis once a week, isoniazid and rifapentine for 3 months, but for children 3 months and above, 3 years and above, 3 years and above. But I don't think, I'm not sure if we have that available in ours right now.
From Dr. Carolisa Pontanilla, how about for allergic reactions to TB drugs? What are the alternative meds?
So these are cases which we usually refer to our friendly allergologist for desensitization. And this is where the second line drugs might come into play if there are really adverse reactions with the first line drugs.
From Dr. Emily Jean Holgado, thank you for the updates. For a 1-year-old patient with only one enlarged cervical lymph node, no exposure to TB patient, what is the next best diagnostic to detect extrapulmonary TB?
Okay, so this is where probably a therapy, at the trial of antibiotic therapy can come into play. And again, this is where tuberculin skin testing can play a role if there is no identified TB case as an adjuvant to TB diagnosis. Of course, we know that there are a lot of other infections which can lead to this enlarged cervical lymph node, considering that the age is 1 year old.
From Dr. Grace Katapang, about stool expert, is it possible that the TB bacilli will be destroyed by gastric and intestinal enzymes, rendering it less effective?
I did not parang there's a way to still get the genetic material from the stool because of the reagent which is added to the stool specimen. So so even if there's a way for the technology to be able to extract the bacterial, the genetic component of the TB bacilli.
Okay. So that will be our last question, Dr. Thank you for your expertise, and thank you for our audience for participating in the question and answer.
Thank you.
Thank you.